Hi, my name is Donna Overman. I'm a registered nurse and I'm enrolled part-time at Lock Haven University in the bachelor's program RN to BSN online program. I'm in the critical care nursing class and we have been asked to do a presentation on YouTube on advanced placement of airways. So I'm going to be covering the anatomy of the airway. The anatomy of the airway begins with the nasal passages into the sinuses, the oropharynx, the nasopharynx, extends into the hard palate, the soft palate, the esophageal area, has the uvula, as well as the epiglottis and the cartilages there. When you are intubating the upper airway, you will see the vinicula. It is at the base of the tongue right before the epiglottis, and that is where you would view your vocal cords for intubation. The lower airway consists of the cricoid cartilage, the tracheal cartilage, the main stem right and left bronchus, as well as the alveoli. Methods of oxygen delivery. The type of oxygen delivery method depends upon the patient's condition. The oxygen delivery method is divided into high flow and low flow, ranging from nasal cannula, face mask, venti mask, non-rebreather mask. The percentage of oxygen delivered ranges from 22 to 100%. Changes in the patient condition which would warrant us to reassess the patient would be respiratory insufficiency, low oxygen saturation, airway obstruction, respiratory failure, respiratory arrest, cardiac arrest, and hypoxemia. In preparing to intubate our patient, we would need gloves, suction with a rigid or a soft catheter, bivalve ventilator mask, oxygen supplement, which is attached already, a CO2 detector indicator, a stylet, endotracheal tubes, cuffed and uncuffed. Uncuffed is for children, cuffed is for adults. They come in different sizes for adults ranging from 7 to 7.5 to 8.0. And as you can see, Mo is actually intubated right now. We need syringes, a 5 to 10 cc syringe to inflate the bulb on the endotracheal tube. We need lubricant and an oropharyngeal airway, which is a rigid airway that we would need to keep the tongue displaced and out of the way when we try to intubate. We would need laryngoscopes. We could use the curved blade, which is the Macintosh, or we could use the straight blade, which is the Miller blade. These do come in different sizes. The Macintosh blade is a curved blade, and primarily the size used for adults is between 3 and 4. The Miller blade primarily is used for children because it's a straight blade, and those sizes range anywhere from 0 to 4 as well. Oropharyngeal airways are the rigid airways that we use, as I said, to displace the tongue out of the way when we are preparing for intubation. We also have nasopharyngeal airways. They are a soft, pliable tube, hollow tube that is inserted into the nostril to assist with ventilation. It bypasses those obstructions. The selection of the size, it's measured the distance from the tip of the nose to the earlobe, and when you insert this, the bevel is toward the base of the nostril, toward the septum. Those are nasopharyngeal airways. Laryngeal mask, the LMA, is an advanced airway that is considered an alternate to an ET tube or an endotracheal tube. Size 5 is used for adult males, size 4 is used for adult females. This device is pre-hospital and in the emergency department. This is the LMA tube. We also have the bivalve ventilator mask that is attached to supplemental oxygen. The air reservoir inflates and it has a one-way pressure valve. Endotracheal conva tube. This is a dual tube. It is an invasive airway device. There are two sizes, 37 French and 4, and that is for 4 to 5'5" individuals. We have a 41 French for greater than 5 feet tall. 2 inflatable balloon cuffs are present. Insertion is done blindly, and you need to make sure that if this is inflated, that you are listening to breath sounds, right, left, and over the epigastrium. If you do not hear breath sounds, then you need to pull the tube back after you deflate the bulbs, and then insert it again, and then re-inflate the bulbs. And if you don't hear breath sounds, then you need to pull the tube out. We also have the laryngeal king tube, which I do have a sample here. This is based on our color scheme. There is yellow, red, and purple colored tubes. These are also done without a stylet. They're just directly inserted in. and this is the airway of choice for surgical patients. The advanced placement of the airway is essential for all patients in all areas of critical care, whether it be pre-hospital, ICU, nursing. It is essential that the nurses reassess consistently across the board for our patients to ensure that they are not having any airway problems at all. If we see a change in their condition, it's our job to notify the provider so they can come and assess the patient. In addition, we use our ACLS protocol to allow us to accurately assess our patients and care for them. Thank you.